So when you're having your kind of diversion talk, what are going to be your, absolute and relative contraindications?
And again,
Not many.
yeah, there's not many. This will be a short conversation. No, look, again, like you said, we do, I think, more neobladders than most around the country. And over the years, I've sort of examined the various contraindications. I told you, we discussed one of them, being the positive urethral margin. Certainly an invasive tumor is still a contraindication. The patient age is certainly not a contraindication. I think ECOG status or performance status is more of an indication for choosing one diversion versus another. I do have what I think is a fairly balanced discussion. This is a topic on its own. One of the things I think that when urologists are presenting the urinary diversion options to patients is they'll they'll describe the three diversions, but they'll say, yeah, ileocondylar, it's really simple. You don't have to do anything and it just comes out. The complications are less. It's a faster surgery. Neobladder is fine, and the gestures and what follows is a negative sort of connotation, and the infection rates are higher. It's more complicated. And the patient said, and you have to catheterize yourself and you'll be leaking. The patient thinks, why do I want that? I say the same thing, but I go into more detail. You might have to catheterize yourself. That rate here at USC is 10 to 15%. We've published on this multiple times. It's not the same catheter that you had after TURBT. This is in and out. You don't have a prostate in males. It goes in easier. So as soon as you say catheter, patients think of their TURBT experience. The other part is incontinence. Again, you just saying you'll leak. The patients are thinking their bed is wet. No, that's not the case. 90% of patients are continent during the day. At night, 50% of patients are leaking, but they're leaking into a pad or a diaper, and they're typically not completely wet or soaked. So I think characterizing these will help the patients decide one way or the other. And I think having a standardized sort of approach and discussion with the patients and really saying, well, in my hands, it might not be like this, but other centers perhaps have better outcomes and they do it more often. Having said that, it doesn't take us much longer to do a neobladder just because of the frequency and all the team that's involved. It takes us about 45 more minutes to do a neobladder than an ileal conduit. So it's not a long operation for us. The complication rates at USC are not higher. In fact, if you look at our series, our complication rates are higher for ileal conduits because of that selection bias of the older, sicker patients getting ileal conduit. So ironically, that complication rate is higher. CKD is a big one. And we have a paper coming out very shortly that will challenge the notion of CKD being a contraindication. Now, I'm not talking about creatinine in the mid twos and someone who's progressively having renal failure, but this notion that we have a cutoff and a creatinine of 1.8 or 2.0 is the cutoff. I've done plenty of neobladders in patients with borderline renal function, and the key here is acid-base balance, and you have to give them sodium bicarbonate to balance the acid-base issues. And then about 3 months out and 6 months out, once the macrovilli will flatten and you get less exchange of the bicarbonate and chloride, then the patients settle down and their renal function will actually remain completely the same. Simply stated, a neobladder in and of itself will not lead to further deterioration of your kidney function. That makes no sense. Why would it? It's really the acid-base balance, and that's all. Once you manage the acid-base issues, then that's fine. It is work though, and you do need to keep the patient on a much closer sort of follow-up routine. So those are so the major ones for me are liver disease. I would not do any kind of diversion in liver disease, invasive tumor, someone whose manual dexterity is not good in case they do need to catheterize, or someone who's just not motivated, someone who's sedentary and not motivated to have a neobladder, and they really could care less one way or the other. I think they're better served with an ileal conduit.